Thank you all for having us here today. We so appreciate this opportunity to share information with you about Parkinson's. We so appreciate you sharing your evening with us, so thank you for that. Like Luann said, my name is Michelle Shepard. I'm the Community Outreach Coordinator for the Parkinson's Foundation Heartland Chapter. Today I'm going to share with you just a few brief slides about the Parkinson's Foundation, what our work is that we do for the Parkinson's community, as well as the many free resources that we have for you. And then after that, I'm going to turn it over to Dr. Muhammad, who is going to walk through the bulk of the presentation today. So for those of you who are new to the Parkinson's Foundation, we are a national organization. We have 17 chapters nationwide, with our local chapter being based right down the road out of Leawood, Kansas. We cover a 4-state region: Kansas, Missouri, Iowa, and Nebraska. And we really are here to support the Parkinson's community. And that represents around 1 million Americans living with Parkinson's disease, 10 million worldwide, and we have another 90,000 that are newly diagnosed every year. So we're very much here to support that Parkinson's community. It is the second most common neurodegenerative disease behind Alzheimer's. Our mission is to make life better for people with Parkinson's disease by improving care and advancing research towards a cure. In everything we do, we truly build on the energy, the experience, and the passion of our global Parkinson's community, which is all of you that are here today. Our goal is really to be a trusted partner for you with information and resources to really provide you with the knowledge, the information that you need for this disease. Through our work, we bring together people with Parkinson's, those who care for them, as well as those medical professionals who are treating them and researchers who are fighting for that cure. And we really address this in 3 ways. First, we support cutting-edge research that leads to breakthroughs in treatments and eventually a cure. That is our goal. We also ensure that every person with Parkinson's has access to the best possible care. That is one of our major goals. And then lastly, we empower people with Parkinson's and their families with the necessary resources and emotional support to live well. The ways that we advance research towards a cure: since our founding, the Parkinson's Foundation has funded almost $450 million in groundbreaking research and care. We have also, since 2010, provided 700 scientists, almost 700 scientists, with research grants, helping them to transform the way they diagnose and treat Parkinson's. We're pleased to offer PD Generation. You might have heard of this. It is a national research initiative that provides genetic testing for PD-related genes, as well as genetic counseling, all free of charge for participants. The testing is administered through on-site facilities like KU Medical Center, or you can do an at-home cheek swab test. The goal of PD Generation is to leverage genetics to help uncover what is responsible for slowing or stopping the progression of Parkinson's. This knowledge will help us to optimize Parkinson's treatments and advance clinical trials. Through Parkinson's virtual biotech, we provide funding to companies looking to develop new therapies to treat as well as cure Parkinson's, with the goal being in years, not decades. So very aggressive, something we're investing heavily in. Our vision is to ensure people with Parkinson's have access to equitable and quality care, and we're working towards that in a few different ways. The first one is through our global care network, which includes centers of excellence as well as comprehensive care centers. We provide care to more than 200,000 people every year throughout the world through those 2 organizations that we have. And facilities must demonstrate exemplary multidisciplinary care to obtain this prestigious designation. And KU Medical Center is your most close in proximity of one of those that is nearby as a center of excellence. We offer specialized professional training programs to educate nurses, physical therapists, other medical professionals so that they can provide better care to their patients. And we also provide specialized Parkinson's training for long-term care facilities, home health agencies, through our community partners and Parkinson's care programs. And I'm sharing all this with you just to give you a background on Parkinson's Foundation, the many facets that we provide, just for a broader understanding. Additionally, the Parkinson's Foundation offers a wealth of resources to help guide you along all the stages and symptoms of Parkinson's. I encourage you to visit parkinson.org, which is our website, to explore the many topics that we have available, from research, symptoms, resources for living with PD, and how to get involved in the organization with Parkinson's Foundation. These resources are all available in a variety of formats. We have, just to show you some examples, if you didn't see on your way in, we have books, we have fact sheets, we have hospital safety guides, just a variety of formats on the website. We have videos, podcasts, we have blogs, we have discussion forums. So depending on what your modality is of how you enjoy learning, you can go on our website, parkinson.org, put in a topic that you want to research, and literally you will come back with, sometimes it could be up to 100 different things that you can look at. You can then filter on, am I an auditory learner? Do I want to listen to a podcast? Or am I visual? Do I want to see a video? Or do I want to read? And so you can check the box of how you want to absorb that content. So I encourage you to go to parkinson.org. I think you'll be very impressed with the amount of information that's there to help you with your journey. The QR code on the screen, if you want to go to our self-service ordering portal, you can go there and order, shipped directly to your home. I also wanted to highlight our helpline. The phone number as well as the email address is on the screen. Highly recommend utilizing them if you are not already. They are wonderful. These are highly trained Parkinson's specialists. They're there Monday through Friday, 8 a.m. to 6 p.m. Central Time. And these are nurses, health educators, social workers, very, very knowledgeable. And please utilize them. I call them for questions that I get that I don't know how to answer. They're fabulous. They take almost 26,000 calls and emails every year. It shows you how much they're used. We also offer virtual education programs through our PD Health at Home. This is an interactive series designed for Parkinson's community folks that you can participate in from the comfort of your home. So truly, you can call in with your camera on, your camera off. You can be dressed to the nines. You can be in your PJs. We don't care. We just want you to join, truly. It's programming offered every Monday, Wednesday, and Friday, and it's topics on wellness, exercise, and mental health. You can learn more at parkinson.org/pdhealth. And again, this is another great opportunity for you all to please join us. So we hope you continue to connect with us, whether it's through Moving Day, through our social platforms, or through the virtual programming that we mentioned at PD Health at Home. I encourage you to use the Parkinson's Foundation website, parkinson.org. Go out there and research. You'll be amazed with what you'll find. And please utilize the helpline. It really could be your first point of contact between those doctor's appointments to really utilize them to support you. All right, with that, I want to thank you very much for this opportunity to be here with you all today. And I am now going to turn it over to Dr. Muhammad. It is my honor and pleasure to introduce him. He is my partner in crime. He is also on the board of the Parkinson's Foundation. And this is Dr. Muhammad, I hope I don't butcher this, Nishatizada. Did I do it? Yeah. I always call him Dr. Muhammad or Dr. M because I struggle with the last name, and he's always so patient with that. But please call him Dr. Muhammad, Dr. M. That's what his patients affectionately call him. He is with the University of Kansas Medical Center, which, as we mentioned earlier, is a Parkinson's Foundation Center of Excellence. Highly knowledgeable. You all are truly going to enjoy him. He is such a gift.
You know, I came here 2 years ago, and I recognize some of you from attending previously, but this is something that's very special for me to be able to come and participate. You know, it's April, and of course it's always National Parkinson's Awareness Month, but just being able to come visit Lawrence and see all of you is really terrific. I actually went to medical school at KU, so even though I spent very little time in Lawrence, I did work with a internal medicine doctor here in Lawrence during my training, but I'm a KU grad, and so that's my medical degree. Today I'm hoping that we can talk about just an overview, a Parkinson's disease 101. But I want to make sure that we have an opportunity to talk about a lot of different concepts. Because when you do an overview talk, there can be a lot of information. And sometimes that can be kind of overwhelming for people. But I just want you to know, not so much all the details, but just to be able to realize that these topics are all relevant to Parkinson's disease. And that these are things that you should be asking questions about, reading about, thinking about. I can't say enough about how great it's been to work with the Parkinson's Foundation. I finished my movement disorder specialty training in Parkinson's disease 15 years ago. And that's when I came back to the Kansas City area. The Parkinson's Foundation heartland has changed a lot, even over those last 15 years. But the people who are involved have been terrific. It is very meaningful for them and personal for them to be participating. And just, when when I reached out to Michelle and I said, I'm coming to Lawrence to do a talk. Do you want to come and bring some? This is exactly, she's always like above and beyond like all the stuff that they brought. It looks like 2 truckloads worth of material back there. So please help yourself. These are all very useful reading materials. I do want to have a few disclosures, which is that I'm not receiving any type of financial payment or anything to be here. I want to be here. I'd like to spend my time and come and do this. I actually am, as Michelle mentioned, on the board of the Parkinson's Foundation Heartland, which means that I give them money, and I like to do that because this is a project that helps so many people, and especially being involved with Parkinson's care. I have not had outpatient clinic since July 2016. I work as a neurohospitalist at KU, so I see people who are in the hospital. So I'm really glad that Michelle touched on the hospital safety report. This is something that on a national level I was involved with great people like Annie Brooks and Emily Buteau and Shira Rosenfeld, who are working with the strategic initiatives part of the Parkinson's Foundation to make sure that systematically the quality of care happens to people all over the United States. We all know people that we admire, and we all have had good and bad doctors that we've run into. The Parkinson's Foundation doesn't allow one person to dictate how care should be. They empower people to raise the level of care to everybody, no matter which doctor you have, which hospital you go to, what your other situation is. And especially over the last 3 to 5 years, the projects that they're working on are making a huge impact. And that's really important because one of the projects that they've just finished in the last several months is to actually identify how many people have Parkinson's disease. They were able to go back and look at Medicare insurance data without identifiers. It's all decoded, de-identified. And it seems that the number of people with Parkinson's disease have probably been underestimated by 50%. So we know that there's at least 1 million, but it might be closer to 1.5 million people. And so this is important because since I don't have clinic, I can't have appointments to help people with Parkinson's disease. But at the end of the talk, I'll give you some names and contact information for some of my colleagues who do. The other thing that they've looked at from the Parkinson's Foundation is what percentage of people with Parkinson's are actually seeing a fellowship-trained movement disorder specialist or Parkinson's specialist, because I did additional training after being fully trained as a neurologist. I went for another year and went to Houston, Texas. I was at Baylor College of Medicine with the great Dr. Joe Jankovic, who is still helping people with Parkinson's fight through this, even though he's in his late 70s now. No plans on retiring. But he really mentored me, and when I came back, the number of people who need Parkinson's care, 9% see a movement disorder specialist. The most common scenario is that about 50% of people are under the care of a general neurologist. But many people are only seeing a primary care physician or other provider, maybe a nurse practitioner or PA, to help them manage their Parkinson's disease. And that's why it's so important to be familiar with these topics, because even if you have a care provider or a physician who's not extremely knowledgeable about Parkinson's disease, if you take some of the things from this talk or some of the things from the reading materials in the back, and you go back to those people, they're helpers, right? They're supposed to help you navigate problems. And if you ask the right questions, they can look into it. They may read some of the same resources you have, or call the Parkinson's Foundation, or reach out to somebody who can help and try to come up with a strategy or plan that can help you as an individual under their care. And I know this to be true because it happens on a daily basis. People will call me and ask questions about what they think they should do with their patient. And so I just want to cover some of those disclosures. I also want to mention that some of the treatments that I'm going to talk about are not FDA approved for the reasons I'm going to talk about them. And that's called off-label use. And that doesn't mean that it's bad. Usually if you jump through the hoops to get something FDA approved for one thing, then there are a lot of studies that happen off-label. And sometimes there's not enough information to be able to go back to the FDA and say, let's get it approved for all of these things. But that doesn't mean they can't be helpful. And many times the treatments that we use for one thing can be useful for something else. So I just want to mention that because not all of these are FDA approved treatments. Okay, so a little bit about terms. Parkinson's disease is one of those conditions that has a person's name in it, named after James Parkinson. And James Parkinson was not a medical doctor. He was actually a surgeon. And in England in the early 1800s, there was a difference. In fact, the joke was that medical doctors were called doctor and surgeons were called mister. But there was a period of time when I was going through training when they said, you know, all of these named diseases or named medical conditions are a bunch of people who lived a long time ago. Nobody knows who they are. It's like a historical thing. Why do we call things with people's names? And so they were trying to get away from some of these. But Parkinson's disease is here to stay, I think. Like people have looked at these other terms, and frankly, these terms are not great. But there are other terms that are used, like paralysis agitans or shaking palsy. My least favorite term here is Parkinsonologist, which is, I guess, what I am. Like, most of the time people will say movement disorder specialist because Parkinson's is about half of what movement disorder specialists work on, but there are other movements that people can have as well. And then sometimes people will ask, what's the difference between Parkinson's disease and Parkinsonism? Well, Parkinsonism is when you have some of the features that I'm going to talk about in depth that are describing what a person has. And if you look at all the people who are Parkinsonian or who have Parkinsonism, about 80% of them have regular or what they call idiopathic Parkinson's disease. The other 20% of people usually have something that's like Parkinson's disease, but it may be more atypical. And we'll talk a little bit about some of those features as well, because there are ways to tell the difference. Symptoms. People go to their doctor to talk about symptoms. They go online. 20 years ago, when I was a neurology resident, and the internet was only about 10 years old at that time, the number one reason why people at that time, 65 and older, were signing up for the internet was so they could look up information about their medical problems. And so, for our younger generations, people have been using the internet now for a long time. And so I think, the problem is that symptoms in neurology, not just Parkinson's or movement, but just in neurology, are notoriously unhelpful. Because you can go to a computer and you can put in shakiness, stiffness, slowness of movement, neck pain, any type of symptoms, and the computer will try to solve that problem for you, but it's always going to come back with fibromyalgia, multiple sclerosis, Parkinson's, because all of these conditions have some of those symptoms. Some people have some symptoms more than others, but symptoms by themselves are not helpful at figuring out what the problem is or even what to do about the problem. So I just wanted to say that because we're not going to talk a lot about symptoms. I am going to focus more on signs of the disorder, and then we will come back and address some of the problems that people have that are non-motor, and they may seem like symptoms, but they're actually signs or disorders themselves. And to talk a little bit about that. But every symptom that a person has requires more careful investigation. So if somebody says, I'm dizzy, that by itself is not helpful. If somebody says, when I roll over in bed, for maybe 30 seconds or 45 seconds, I feel like the whole room is spinning, so I started holding real still because if I move suddenly, it's going to be a problem. That might be vertigo from calcium rocks or otoliths that build up in the canals in the inner ear that are touching hair cells and causing room spinning. That would not be explained by nerve damage to the inner ear, which might cause the same room spinning, but it would last for several weeks at a time, maybe even a month or two. Vestibular neuronitis from a viral infection. So the story, tell me 3 or 4 sentences or 2 or 3 paragraphs about the symptom. That's how you figure out what's going on. So it's not the symptom, it's the entire history. So what are some early versus mid symptoms? Many people who are not familiar with Parkinson's, even among medical professionals, if you say Parkinson's disease, what do you think of? They'll say tremor. But tremor, actually, many people with Parkinson's disease will never develop tremor. It's been estimated that 20 to 25% of people with actually idiopathic regular Parkinson's disease will not have rest tremor. So these are the types of symptoms that you're more likely to see early on. Some people will actually act out dreams or sleepwalk, and this can sometimes happen years or even decades before Parkinson's motor symptoms happen. Loss of smell. This can sometimes be 5 to 8 years ahead of time. Chronic constipation. Not so much straining, again, there's always a story, but just fewer bowel movements. You know, I used to have bowel movements every day, and now I have like maybe 2 a week. That's a change in the amount of time that it takes for the digestive particles to pass through the system. Shoulder stiffness was actually the #1 presenting motor symptom when I was a fellow back in Houston. Because a lot of times the shoulder that doesn't move as much when people are walking, that can show up as either misdiagnosed as arthritis or bursitis, some sort of other musculoskeletal explanation for the shoulder pain. Small steps. Just decreased dexterity. Somebody throws you a ball and you're just sort of fumbling with it, or just not able to react as quickly. Decreased facial expression. Changes in personality. That's sort of vague. We'll talk more about some of these things. But then there are what I call the cardinal features of Parkinson's disease. And so some of you maybe have been familiar with this for some time, and you may even have come across, there's a mnemonic that gets used, TRAP, TRAP, as like the 4 features of Parkinson's. T referring to tremor, at rest. R, rigidity. A standing for either akinesia or more commonly described bradykinesia, either loss of movement or more slow, incoordinated movement. And then postural instability or loss of postural reflexes. And absolutely, if you look at even a lot of the older terminology or even just the older books that were written about Parkinson's disease from even 20 or 30 years ago, these are sort of the 4 that are mentioned. But I need to mention 2 other features because sometimes people have these other features, but they don't have all of the other 4. And so one is called flexed posture. And the other one is freezing or motor blocks. Now I'm going to go through and explain some of these a little bit more in depth. So if these are not familiar, don't worry. So tremor at rest is much more likely to happen at the end of a limb. So normally what you'll see is that it'll be like in the person's hand, or sometimes you can see it in the foot. Now, your head is not really a limb, but it is more likely to happen down around the chin area or near the mouth. So if a person is having what seems like regular tremor in a different part of the body, that should make a neurologist think of something else. As a person who works full-time in a hospital and sees people who may be having seizures, for example, you might see somebody come in and they have like what looks like tremor or some sort of jerking motion near their eye. And that may be the sign of a small motor seizure. And so details of location in the body, how things present, how quickly are the movements, how slow are the movements, do they come and go? Those are all important parts of understanding what's happening to people when you're a movement disorder specialist. Now, in the old days, when pharmacists would actually make their own pills, before technology, they would take the little dough and they would roll the tremor back, or they would roll the pill back and forth. And this is where they got the idea of pill rolling tremor. So it's like you basically will see this sort of movement, and especially around the thumb and the index fingers. But as I say, you can sometimes also see it. The lips, chin, and jaw can have tremor. Normally, the tremor happens when a person is at rest. So if a person, for example, changes posture, their tremor should go away. If somebody actually changes posture and right away they start having tremor, that's not like rest tremor. That's actually postural tremor or kinetic tremor if somebody's moving. If somebody has mostly postural or kinetic tremor, that's usually the sign of a different type of disorder. Similarly, if you have postural head tremor or neck tremor, or if you protrude the tongue, and then the tongue is actually having tremor. These are all often the signs of something else. Most often, essential tremor. But where it gets complicated is that there are some people who have what seems like essential tremor, maybe even some of the people in this room, who over time will start to look more and more like Parkinson's. And there can be some overlap between those. And so that's one of the things that we sometimes run into, because essential tremor is about 10 times more common than Parkinson's, even with Parkinson's being so common. And so some people will say, one of my parents or maybe half of my brothers and sisters also have tremor. That may be like a familial essential tremor, but sometimes over time people can have some Parkinsonian changes from that as well. Similarly, people who have cerebellar changes in the very back of the brain from conditions like multiple sclerosis, they can also have postural or kinetic tremor. And this can take some time to be able to diagnose and get an answer more accurately. But I also want to talk about re-emergent tremor, because sometimes if people change postures, and then maybe 15, 20, 25 seconds later, you can start to see that tremor will come out again. And that's called re-emergent tremor. That's as if you are now, that has become a rest position. And so people who are low on dopamine, people who are more likely to have Parkinson's, will have this re-emergent tremor, even though it's in a postural position. I include this because this would be an example of kinetic tremor. Somebody's trying to draw a spiral that gets bigger and bigger and bigger. And the secret is that when you go in a 360-degree motion like this, you're going to reach breaking points where it's going to be more likely that the tremor will come out. And then there will be other places where the tremor may not be so visible. So you can see here on the left side that if you were going to draw a line, it would almost be, the line would be sort of at an angle like this, where the size of the movements are much bigger when they are parallel to that line. But then if you draw a line perpendicular, sort of from the 11 o'clock position down to 5, the amplitude isn't as high. And that's because as you go through that circle, it's more likely to bring this out. People with essential tremor are going to be much more likely to have tremor with movement. People with Parkinson's disease, they might have small or slow spirals that don't seem very far apart because of the smallness of the handwriting from the bradykinesia, which I'll talk about soon. Rigidity is a sort of stiffness of movement that you often see. So if you just very passively try to, this hand will be the examiner, and this hand will be the patient. So if you just very slowly, without a lot of velocity, just sort of try to go through the full range of motion, normally people will be fairly loose, especially if they're able to relax. But if a person has Parkinson's, if you go through that process even very carefully or slowly, you'll see that it will be sort of stiff, almost like the resistance is increased. Like if you were to turn up the resistance on a stationary bicycle and you'd have to sort of pedal harder or you'd have to be able to move through it. That fighting through that stiffness, that's rigidity. So if you have tremor, like rest tremor, with the arm that's having rigidity, as you go through that process, as you're going through the 360 degrees, just like you're drawing the spirals, you're going to be more likely that you're going to get some clicking. Click, 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 click. And this is why they call it cogwheel rigidity. But if you pick a part of the body like the neck may not have tremor, especially if you don't have essential tremor. So if you just try to gently move a person's head or neck and see how stiff it is, it will be stiff without tremor. And so that's lead pipe rigidity. It doesn't matter. It's this, whether you have tremor or not, you have rigidity. So these are some of the terms that get used. But as you can imagine, if your muscles start to get real tight or stiff, there's nothing actually wrong with the muscles themselves. The area of the brain that's deciding what the tone of your muscles should be like is the part that's affected by Parkinson's. But if the muscles are affected, then muscles are people too. And so if muscles hurt, you're going to be more likely to complain of pain, discomfort from that. And so rigidity is definitely something is sometimes alone a reason why people will say, I'm ready to start taking some medications for Parkinson's because I just, taking a bunch of Tylenol is not making this any better. And sometimes people are misdiagnosed with something else. The one condition I didn't mention is rotator cuff syndrome. And that's actually more likely to occur when people have Parkinson's disease. Because if the brain is sending the signal to be really stiff and that shoulder is locked up and not moving, as you try to do things with it, you're going to be much more likely that the muscles could actually tear in the rotator cuff. And so there are many people who 2 years after they have a rotator cuff tear, they find out that they're starting to have signs of Parkinson's disease. And it was that was going on all along. Okay, I promised bradykinesia. So bradykinesia is a long word that just means slow and uncoordinated movement. So there may be slow reaction times. This can make all the things you do every day take longer because movement is, just not working as well. And so sometimes people have whole body slowness, and that's definitely visible. But there's a lot of impairment of fine motor movement. And when we think about how much we use our hands just to do things throughout a day, this can be a tremendous source of frustration for people who start to have this. Now, it's not always slow. Sometimes people think, oh, Parkinson's, these people are slow. No, there are some people who actually are pretty fast and even kind of hypomanic. But if they do the tasks over and over, there's a certain smallness of the movement. So if I have somebody, for example, tap their fingers up and down, if we did it 100 times, everybody's fingers would start to be, it would be heavy and it would start to become slow. But if you do it 10 times, that's a very reasonable amount that somebody who doesn't have weakness is going to be able to do that and repeat it multiple times. But if you get some people, they'll go really fast, faster than I can do it, and they could have Parkinson's. So it doesn't matter the speed. It's that, does it start out big and fast and become small and slow? So I'll demonstrate this using what's a little bit more obvious, which is opening and closing my fist. So I like to have people open their fist. So if I say, if you open the fist really big, okay, it shouldn't change by the time you've done it 10 times. But if after 3 or 4 or 6 or 7 times, you start to see it's getting slower, or it's not opening up as much all the way, that's bradykinesia. I try to tell primary doctors and nurse practitioners that if you would just do these maneuvers, you could in 2 minutes figure out whether somebody looks like they have Parkinson's or something like this. Because there are a lot of times where people will say, I just thought they were moving slow because they had arthritis in their hand. So as you can imagine, slowness of movement affecting different parts of the body will have different results. So if you have less swallowing, because you're not moving as much in the automatic swallowing portion, then saliva starts to build up and people will have drooling. Hypophonia. If I talk with a certain level of voice, but as the further along I talk, I start to become slower or more quiet. That's bradykinesia of voice production, sometimes called hypophonia. Bradykinesia of facial movements. These are the masked faces and the loss of emotional response. One of the biggest things people have told me with Parkinson's disease is that they lament, of all the things you could complain about, and there's many, is that people feel that people misunderstand them. Because they say, I'm still the funny and happy person I used to be, but because everybody looks at my face and they just think I'm sad, or they have no energy, or that I'm not interested in doing things. And some of those things do happen to people with Parkinson's disease. That's apathy, but just the misunderstanding. Dr. Stan Fisher, one of my own colleagues, and I've learned a lot from him as well. He used to work as the movement disorder specialist and director of neurology at St. Luke's in Kansas City. And he would tell a story about how, if you draw 2 dots and a semicircle facing upward, what is that? And people would say, it's a smiley face. And he would say, no, it's 2 circles and a semicircle. But our brains are wired to look at an emoji on a text message or, something that's written, and to interpret how does that emoji feel? So if somebody looks like they're sad, then we're sort of trained from an early age. I have a 4-year-old at home, and when she was about 3, she started reading the room better, and she would say things like, Daddy, are you happy? Or, Mommy, are you sad? And she would just sort of ask, and we would be like, fine, and no, I'm happy, yes, or I'm sad, or whatever. But she's just trying to read the room, to be able to read faces and trying to understand how people feel. Smaller handwriting starts out big, but as the word goes on, by the time you get to the end of Nishati Zada, the letters are smaller and, harder to read. That would be micrographia. That reduced arm swing while walking can also be not only just from the rigidity, but because the amplitude of the movement is smaller and slower. And so you can sometimes see somebody walking down the street, they have decreased arm swing. Okay, I mentioned there were 2 other cardinal features. Do you remember? Flexed posture and freezing. So let's talk about that. So if we didn't know this was a Parkinson's talk and we saw the person on the left who was standing there, we'd probably be like, that's an old person, right? Look at how they're hunched over and they just sort of look like all the angles are small. But what if I told you that person is 55 years old? Well, it's not an age-related issue. It's not musculoskeletal. The tone of the body is set so that, I should stand up really nice for this. If I have like good posture, but if I start to have truncal flexion, or if my arms are instead of being at my side, if they're more flexed, if the wrists are flexed, the fingers and thumbs are flexed, all of these angles look like you're curling up almost like into a ball. And then people will turn slowly. This is all flexed posture, because flexion is when you have angles of muscles that are more acute, as opposed to extension. So flexed posture is part of the tone of Parkinson's, even if you don't have the other symptoms. And then along those lines, striatal deformities. So if you have a person, like for example, take off their socks, sometimes the big toe will spontaneously go up. And this is like dystonia, or an abnormal tone from Parkinson's. Or like I said before about arthritis, if you didn't know this was a Parkinson's talk and you looked at this hand, you would be like, it just looks like some of the joints are swollen. Maybe this person has, I don't know, osteoarthritis, maybe even rheumatoid arthritis, I don't know. No, what happens is, instead of having a nice flat hand, the flexed posture allows a person to start having flexion, extension, and flexion abnormalities, where the hand looks like this. So even if you have a person put their hands out, you may see that one side is affected by that. So these are visible things. Not everybody with Parkinson's has these, but these are signs that we sometimes see. Along the same lines of dystonia, sometimes people can get involuntary pulling or contraction of muscles that cause them to pull forward. It just sort of looks like the person on the very left there, and maybe he's just bending over and putting his hands on his knees. But this is actually his normal standing position, because the dystonia in his abdominal muscles, camptocormia, pulls him down. And so the next picture just to the right, which is B, actually shows him after he's received botulinum toxin injections to relax some of those muscles and override the connection between the nerves and the muscles. So that's like a successful treatment before and after. Similarly, the gentleman on the right, that's him bending over almost completely horizontally. His trunk is like horizontal to the ground. But when he sits in a chair or lies down, the sensory input of the chair behind his back or the bed on his back feeds back and actually allows his muscles to relax. And so this is called camptocormia or truncal dystonia. So you can imagine back in the 1960s, when there was less understanding of how dystonia works, people would be like, you can touch the body and like then the muscles relax. Like that sounds like it's like something sort of psychiatric. But it's actually, it's a sensory trick. Geste antagoniste, the sensory input feeds back to the motor cortex, and then the muscles are able to relax. And that's a key feature of dystonia. Postural instability. Early on in Parkinson's, this doesn't tend to be a huge problem. When people work with therapists, they may assess for some of this, and people will say, okay, I'm not able to stand up as straight, and then when somebody tries to pull back, I might, instead of just taking one step back, they might have to take multiple steps back where they have, because their center of gravity is not working. That would be an example of postural instability. But sometimes people with Parkinson's disease, if they're especially on an uneven driveway, they're walking down a driveway, for example, and their center of gravity gets ahead of them. And so what they start out as having really big steps, they might end up having faster and faster, and then they sort of lean forward and actually fall down. This happens every winter, and so you have to be very careful about understanding that, unlike a straight sidewalk, these unlevel ground problems can lead to more falls. But on average, give or take, there's some people earlier, some people later. Some of it depends on the other musculoskeletal problems that are happening. But a lot of people with Parkinson's, they won't actually start stumbling or falling until probably 6 or 7 years into the course. If you are fairly athletic and you're very engaged, it might be later. If somebody's older at the time of their diagnosis and they have a lot of knee or hip problems, it might be sooner. But if a person is falling in the first year or 2 or 3 of their Parkinson's, maybe what you have is atypical, and it may not be regular idiopathic Parkinson's disease. So that's something to think about as you're thinking about what kind of medical evaluations you're thinking about. Okay, the last cardinal feature is freezing, which is also called motor blocks. And so it's just a sudden, temporary, or transient inability to move, and it usually lasts for several seconds. But this is one of the most disabling symptoms of Parkinson's disease. It disproportionately, if it's going to happen, will affect the legs. So, you'll see people, especially as they're about to stand up from a chair, and it's almost like you're driving a manual stick shift. And it's like, okay, this is the portion of the drive where we're going to switch into the walking mode, but the manual gear doesn't shift, and so people are sort of stuck to the ground. And you'll see that they'll try to do stuff to try to pick up their legs or get going, but it's very difficult to get started. Or similarly, when you arrive where you're going to be, okay, we walked all the way over here, now we're going to sit down in a chair, and as you sort of line it up, and then, oh my goodness, the freezing starts. Start hesitation, target hesitation. It's all freezing. Feet often feel glued to the ground when turning or walking through narrow passages, especially if you walk through a narrow doorway or people getting onto or off of an elevator. There's actually some sort of, it's almost like a claustrophobic trigger. Even if you're like, I'm walking into an elevator, I'm not afraid of elevators or claustrophobic. It's not you, it's your brainstem. Your brainstem is like, oh, this is a little tight, and then it locks up. So the very top of the brainstem, it's like the animal part of the brain, lizard brain, reptile brain, is involving the area that involves freezing. And so, or open, people will say, back in the days when I had clinic, they would say, when I'm walking in from the doctor's parking lot, I feel like I get frozen. But some of that is also, again, the brainstem saying, we're in a parking lot. I know you're trying to go to the doctor, but I'm trying to just life or death here. Am I going to get hit by a car? And so people freeze up from that. So it's complicated. All of these same motor things that I'm talking about can affect speech as well. So if you have bradykinesia of speech, hypophonia. What if I had the same tone of speech and didn't make any inflection in the way I present? That would be aprosody. So that also affects the message that's coming across because, listen to how I do it. Sometimes I make my voice go up or make it more interesting, even when I'm talking about big words or things that are boring or hard to follow. Tachyphemia is the same thing as when you have festinating. So the same way people are losing control and then they might just fall forward. If you had speech that suddenly rushes out, it's because it's out of control. So your brain tells you what language stuff to say, but then it's the responsibility of all the motor stuff to bring it out at a correct rate. Stuttering or stammering. Sometimes kids who have stuttering and they outgrow it, it can come back when they have Parkinson's. Sometimes people who have Parkinson's can have new onset stuttering, even if they never had it before. But variable speech rates, sometimes faster, sometimes slow. The loss of motor control affects all of this. And then for some people who are having a lot of rigidity, that can affect not just arms and legs, but even just the tightness of the breathing muscles. So people are having to take really deep breaths because their chest feels tight. That could be, uncontrolled Parkinson's. Or if they're on a bunch of levodopa and having a lot of dyskinetic movements, that can also affect the breathing muscles as well. So I won't walk you through all these criteria, but this is how for many years, others even before me, have looked at trying to decide whether somebody may have Parkinson's disease or not. And this is important because if you think about how we're trying to, especially in the old days, we would just examine people and try to figure out what they have. It's important to be looking at the right characteristics to make the right diagnosis. But basically, if you had bradykinesia and at least one of the other features, that's enough to be considered Parkinsonian. And so if this is one of the reasons why it's probably not diagnosed as much, is because people are not familiar with some of these criteria. And so if you have an excellent levodopa response, this has been going on for more than 10 years, it's much more likely that you have Parkinson's disease. But there are a lot of other atypical features that can show up. So I put causes with a question mark because we don't actually know. It's not like Parkinson's disease is one disease. There are many flavors. And so it's unlikely that it's also due to one thing or one cause. If it were, I think that would be, with all the high-level epidemiology studies, I think we would have come a long way with this by now. But there are some theories like, does a person start off with fewer dopamine cells to begin with during brain development? That could be, but that might feed into how old are you when you start having Parkinson's? Many people will say that they had brain injury or some sort of head injury and had some brain swelling, and then within months or years afterward, they developed Parkinson's disease. So the trauma could certainly be a trigger, especially if somebody is more susceptible. Free radical damage, I mean, there's so much stuff out there in the environment that can uncouple DNA. Some people have iron overload or hemochromatosis. Very few people have manganese, which is a type of mineral that's a metal, but it can build up in a person's liver and in a person's brain and make people Parkinsonian from conditions like that. You might see that if somebody had a long history of like mining or something like that. But small strokes, even occasionally a brain tumor, can affect the areas of the brain that disconnect some of these neurons and make people more Parkinsonian, which is why everybody who is Parkinsonian deserves at least one high-quality brain scan. At least once. It doesn't have to be that you go every year and have another CT scan of the head. Ideally, neurologists and movement disorder specialists would love to see a brain MRI or a head MRI because it's a higher quality picture, and there are some of the subtleties we can pick up on some of the sequences, but it's not something that has to be done all the time, just once to make sure, because even in the 1800s, people would have cancer that spread to the brain and they would present with Parkinsonism, or even like conditions we don't see as much of anymore, like tuberculosis. People would get a small area of infection in the brain and it would be causing them to be Parkinsonian. Medications, especially medicines that block dopamine. Many migraine medicines, like for nausea and vomiting, like prochlorperazine or compazine, metoclopramide or Reglan, haloperidol or Haldol. These are medicines sometimes that are used for psychiatric reasons, sometimes for gastroparesis or other stomach conditions, nausea, vomiting, and migraines. These can increase the risk of blocking dopamine and making people more Parkinsonian. Certain street drugs, not your typical sort of like cannabis or opioids or things like that, but especially injectable things that people would come up with different drugs and then inject it into themselves. There was an outbreak about 40 years ago in San Francisco where a bunch of people came to emergency rooms and were all acutely Parkinsonian. These were all like young people. And what happened was some of them were trying to make Demerol, which is like a pain medicine, but they didn't, there was a side path on the chemistry. Some of these, one of them was like a Berkeley chemistry graduate student. I mean, these people were smart and like, they're just like, I'll come up with my own drugs. But then what happened is they ended up making something called MPTP, and when they injected it, they would basically have Parkinson's. There was a lot of research in the 1980s spent on trying to understand MPTP to be like a cure-all for Parkinson's, but that was really only one step of the pathway. All right, so carbon monoxide exposure, certain viral infections, these can also cause or increase the risk. So 100 years ago when they had the pandemic, the encephalitis lethargica from the Spanish influenza, there were a lot of people who were Parkinsonian afterward. The jury's still out about COVID and Parkinson's. There's this thought that there may have been a small number of people who developed this, but considering how many people were infected and affected by COVID, there hasn't been like a smoking gun that's like a huge amount of. There's been some it's been controversial in the literature. What about association? So pesticide or herbicide exposure, the Parkinson Foundation Heartland, you mentioned those 4 states, Nebraska, Iowa, Kansas, Missouri. This is where a lot of agricultural stuff happens. And so the rates of Parkinson's are higher. Even folks who live inside the city who maybe weren't drinking rural well water, they can be exposed in other ways. I can't tell you how many people have told me over the years, oh yeah, when I was in college, I worked on a golf course. Well, if they were keeping those greens nice and green and, they're trying to keep the weeds off, there's ads on TV now all the time about Roundup and some of this other stuff that's increasing the risk of mitochondrial damage and Parkinson's. But a lot of it is genetic. So when I was a fellow 15 years ago at Baylor, it was estimated that 3 to 5% of Parkinson's is hereditary. And now with the PD gene study that's being coordinated by the Parkinson's Foundation, the numbers are probably like 10 to 15% have a genetic, but it's not like one gene. It's more like, well, there are these 8 genes or 7 genes, and if you have slight mutations in 4 of the genes, then you're going to be much more likely. And this sometimes happens. But for a lot of people who are like, yes, my dad had Parkinson's and half of my sisters and brothers, that might be something that's more autosomal dominant and from one gene. But even then, we've met people who have positive multiple genes. And this is changing how we do care, because as you may have seen in cancer therapy, sometimes now they're able to test what kind of genes you have in your cancer. And if it turns out you have this one or this one, then they can give you these immunotherapies and 70% lower cancer rate. So there's been a huge, tremendous change in how this is affecting care. And we hope to experience a similar type of breakthrough with Parkinson's disease. Not smoking and not drinking caffeine are complicated because, did people who have lower dopamine in the brain to begin with not get a good buzz or a good vibe from smoking or drinking caffeine? Well, then, it's not necessarily that it was like the chicken or the egg. It may just be that people, had low dopamine to begin with. So starting smoking or starting to drink lots of caffeine is not recommended. It's not going to help the course of your Parkinson's. So nice try, Dr. Mohammed. Okay. So I won't go through all of these, but if you have a younger onset, or if you don't have tremor, or if you have more jerking movements, if you have early falls or balance problems, incoordination like cerebellar ataxia, cognitive problems early on, abnormal eye movements, you might have a different type of Parkinsonian condition. Progressive supranuclear palsy, multiple systems atrophy, dementia with Lewy bodies, cortical basal degeneration, vascular Parkinsonism. So even frontotemporal dementia can present with Parkinsonian features, and even some cases of ALS, Lou Gehrig's disease. So these are some things to think about. I want to talk about 2 tests that don't involve going to a doctor and having them examine you. And I'm trained in the old way, so I was all about trying to make a diagnosis without these tests. But it's important that we understand that these tests are available, because I think we'll see more and more people ordering these tests. This is not brand new. This is something called a dopamine transporter scan. I'm pretty sure we had this in Kansas City even back in 2013. It's been more than 10 years. But if you look at the far left, you see how deep in the brain you've got these glowing orange and yellow spaces. Those are the areas that are lighting up with dopamine in the brain in somebody who has a normal amount of dopamine in the brain. So you can see it's sort of shaped almost like a comma or an apostrophe. But then in the panel just to the right, instead, since we're going to stick with the punctuation, it looks more like a period. Okay, and so you've lost those areas that are lighting up a little bit lower in the basal ganglia in the putamen, but the caudate is still lighting up. That's what somebody looks like when they've lost dopamine in the brain, and you can scan them and be like, you are low on dopamine in the brain. You probably have one of these Parkinsonian conditions. The 4 series on the right are just to show that there are various grades. So if you start up on A on the top left, and then go to B, C, and D, this is less and less and less dopamine. So they can even use grading scales now to look at the amount of how much dopamine is lost. This is something that's actually covered by Medicare. How many of you have heard of the synuclein skin biopsy? Very good, well read. This is like literally new in the last year and a half. And there was a nice article reviewing this just a week and a half ago. But if you have ever been to a dermatologist, this is so easy, even I can do it. It's a skin biopsy. And so you get the little green tube. And as you can see, they inject, what's not shown is they inject lidocaine into the skin so that it's numb. You just feel a little bit of a burn. And then that punch biopsy goes deeper in through to make sure you get both the epidermis and the dermis layer. And then when they take that sample and send it to the company, they can specifically stain it to look for alpha-synuclein abnormal proteins that are in the skin. This is like, we don't even have blood tests for this. Like, we literally have had to do dopamine transporter scans or autopsy to figure out whether people have low dopamine in the brain. So this is a huge breakthrough. This is something they're going to remember 100 years from now. Like, this is like revolutionizing the diagnosis. If it turned out that people who have not developed motor symptoms yet from Parkinson's disease could have a skin biopsy with abnormal alpha-synuclein, then if we had treatments that for sure would slow the progression of this, we could do skin biopsies and figure out people early and then get them on those treatments. So this is exciting, but we don't have those treatments yet. Still, we have more work to do on all that. But I just wanted you to be aware of that. I was very touched by the words that Luann said, I mentioned at the beginning, because, I made this slide a long time ago, but I constantly update it. And so this is a list of all the FDA-approved Parkinson's treatments. And as you notice, I graduated in medical school in 2003, which means that 2/3 of the treatments we have for Parkinson's disease have been since I finished medical school. Some of the older treatments are not even around anymore. They've been crossed off. And that's because they don't make them anymore. Some of them have been replaced with newer treatments. Others, it's just been a bad business situation. So if you look down on the bottom right, in 2020, apomorphine sublingual film, that was just approved 4 years ago. They didn't have enough market because it was so expensive and insurances weren't covering it. So they're like, we're not going to make this anymore after all that work and all the research and all the drug reps and everybody. So, medicine is still very much involved with the business side, and it's an important part as we think about coming up with new treatments and who's investing in all this. I got to have some breaking news here because tomorrow the FDA is going to meet and talk about a different apomorphine treatment. This is literally up for discussion tomorrow. So it's not FDA approved yet, but tomorrow it may be on the news if it is approved. I won't walk through all of these different medicines. I had included some slides about this, but just in the interest of time, in the old days before levodopa, people would use anticholinergics, and these are still around, trihexyphenidyl or benztropine. But the problem is because they block acetylcholine, a lot of people will be more likely to have cognitive side effects. So there are many people who are even 50 years old who have a difficult time tolerating these. If your doctor is using these, it may be, and you feel like there's some short-term memory issues or it's difficult to concentrate, may need to be thinking about some other options. Amantadine is another medication that was in the 1960s, was available to treat influenza. And people who would take this because they had the flu would be like, hey, my Parkinson's is doing better. So then they started studying it, and it turns out amantadine also works on the brain, and they still use this even when people go to therapy or rehab, especially inpatient rehab, to sort of perk them up and have more energy. But if you take it late at night, it can cause insomnia. But you have to be careful because it also blocks acetylcholine. So some people have memory loss. There have even been some people who have seizures. And then there are some people who can also get this unusual skin reaction that looks almost like an autoimmune reaction called livedo reticularis. This is sort of a picture of what this looks like. So, if you see this, it's probably the amantadine. They also recommend not using it in people who have heart failure. But it's had a second coming because in the last several years, it's been FDA approved as an extended release formulation, either for reducing dyskinesia and off time in Parkinson's, or the tablet. So one's a capsule, one's a tablet, which is just FDA approved for Parkinson's disease or Parkinsonian reactions to dopamine blockers, for example. So these are some different strategies that we can use it for. There are also monoamine oxidase B inhibitors like selegiline or rasagiline, and there was some controversy early on about whether these might be neuroprotective and save neurons, or whether if you started on them early, it was just a disease-modifying effect, where it might change the trajectory of your Parkinson's. But these are sometimes used just so that you raise your average daytime level of dopamine in the brain. And they come in various formulations. There's one problem with some of the older ones is something called the tyramine cheese effect. And so, because it's not just blocking dopamine breakdown, it blocks a lot of different neurotransmitters that are all monoamines. And so if you eat foods that are high in an amino acid called tyramine, like, for example, older cheeses, aged cheese, fermented foods, red wine, beer, pickled herring, people will, if they are eating these foods and then they're taking a monoamine oxidase B inhibitor, their blood pressure will start to go up and they will start to get very flushed and feel uncomfortable and have to go to the hospital. So they've labeled a lot of these as having the tyramine or cheese effect. But rasagiline, they went back and did studies, and it turns out it's the older ones, not the newer one. selegiline is the older one, but it's also available as an orally disintegrating tablet. Dopamine agonists are sort of like substitute teachers. So if you're low on dopamine and you take levodopa, it will replace low dopamine in the brain. But if you take a dopamine agonist, you'll just push the dopamine buttons as if you were replacing dopamine. But when you start pushing a bunch of buttons, you could get other side effects. And this is why sometimes as people get older, people are using less ropinirole, pramipexole, apomorphine, and using more levodopa, just because it's replacing low dopamine rather than stimulating all of the different dopamine receptors. So this is why as people get older, if they're on high doses of these, their blood pressure can bottom out, orthostatic hypotension. They can be more drowsy or even have sleep attacks. So I'm not talking about just being drowsy, but people can literally be having a conversation and then they just sort of have an attack of sleep, which is why when people start taking these medicines, they recommend that people not drive for a week and just see how you do with it first. They also have a transdermal patch. It's been around a long time, where the medication is absorbed through the skin. So one thing on this slide that's not correct, and I complain about this, is that the second row where it says carbidopa, levodopa, orally disintegrating Parcopa, that's no longer available, which is a huge loss because as a hospitalist, if people were NPO, where you're not supposed to eat anything by mouth after midnight because you're going to have a surgery, or if people needed bowel rest for whatever reason, we could give them something to disintegrate under the tongue and it would be absorbed. But going back to the business side of things, there were only 2 generic companies that were making this, and they didn't see a market for it because it was sort of a niche drug, and so they've stopped making it. And so, now we have to use other types of strategies when people are in the hospital. But as you could see, there are many formulations of levodopa, and because still, after now 55 years, levodopa is still the medicine that helps people move the best per dose. So some people, as they get further along into the course of their Parkinson's disease, they may start to develop motor fluctuations. And so you'll see doctors will ask about this. Okay, are you on or are you off? And some people will be like, I don't know what you're talking about. Like, why do you guys always ask all this stuff? If I'm 2 hours late on my medicine, I have no problem. That's great. I'm glad that you're one of those people. Because a lot of people who have motor fluctuations, if they're 10 minutes late on their medicine, they start to feel an involuntary pulling in their hand, or their foot is cramping, or they feel an uncomfortable sensation, almost like the medicine's leaving their body. And so if you're on and moving well, then you have a good amount of levodopa in your system. If you've reached the point where that medicine is leveled off, then you're sort of off. The only thing worse than being off for many folks is wearing off. If somebody were just off all day and not moving very well, they would probably be more comfortable than somebody who's actively wearing off because of how uncomfortable that is. Some people will even have a feeling of anxiety. And then people start to be thinking about, I got to get to my next dose. Then they become clock watchers. Some of them even want to take the medicine early, and then they build up too much in the system and have other problems. But as you're wearing off, people can get dystonia, they can get freezing, they can get this akathisia, which is this creepy crawly kind of restless leg syndrome-like feeling, although not just in the legs. And so just, definitely an important part to think about. Then there's the other side of what happens if you have too much levodopa. Well, early on, not a whole lot other than maybe some side effects. Maybe you're more likely to have some nausea. But over time, as the person's normal dopamine levels in the brain continue to get lost, like you saw the dopamine transporter scan, where there was less and less dopamine in the brain, then people become very sensitive to levodopa. So then, even with normal amounts of levodopa, they may get involuntary twisting movements, especially in the shoulders and neck. People will sometimes with the head, and the feet may be moving. But most patients who have this, unless they're having joint pain or some sort of musculoskeletal pain from the movement, they may not be as aware as other people who are looking at them. I've had patients say, I saw myself in the mirror, or I saw a video that my grandchild took, and I was moving a lot, and I didn't realize I was moving that much because they don't feel the movements. They actually feel very comfortable. When they did a study looking at overall mobility, about 60% of people said that they would rather have dyskinesia, that they don't even notice themselves, rather than being off, for example. Only 17% of people thought that being on was better. And so some of it is just body awareness. But this can involve the face, the arms, the legs, or trunk. It can be fluid and dance-like. It's sort of continuous. But sometimes people can also get jerking movements or myoclonus with it, or some dystonia with it. Most often, you'll see this when people are getting so much levodopa all at once. So if you've got somebody who's taking 300 milligrams of levodopa at a time, that might become too much for you, even if you were doing well on that dose. Might have to cut back to 250 or 200. Might have to do smaller amounts like 150 or 100 and put the medicines closer together so that it doesn't wear off. But this is why it requires a fair amount of individualization of therapy. And you see, if you meet 200 people with Parkinson's disease, each one of them may have a very different dose than somebody else. There's also less commonly diphasic dyskinesia, which is right as the medicine's kicking in, people have dyskinesia right away, and then it's sort of they're working okay, and then they have dyskinesia, and then it wears off. It's almost like a glitch in the system, but they call that diphasic or dyskinesia improvement dyskinesia type of Parkinson's, and it's almost like they need a little more levodopa rather than too much. So this is just a graph that sort of shows the ups and downs, like the roller coaster of what motor fluctuations and levodopa-induced dyskinesias can look like. So if you're up in the tan-colored section of the graph, that's sort of above the higher dotted line. That's like too much medicine. So then people have dyskinesia. But then if you are too low in the gray area, then you're more likely to get stuck or akinetic or bradykinetic, whereas you're trying to aim for that middle ground, which is good symptom control. And this is just shown over one day. If we showed this graph over several years, the amount of what those two dotted lines will start to become narrower and narrower and narrower, and then it's almost like you're trying to hit the bullseye. And so this is why we often have to use some advanced strategies when we're doing doses. And that's the bottom line is, without a lot of detail, individualizing the regimen based on personal details. This is, and I'm biased because I'm a fellowship-trained movement disorder specialist, this is where I think people benefit from a movement disorder specialist. You can go for years and do okay, and as long as you're on your medicines and moving pretty well. But then when it gets complicated, I didn't know people could take levodopa 7 or 8 times a day. That seems like way too much. That's because they've never prescribed it before. If you met even 50 people with Parkinson's disease and managed their medicines, you would see that sometimes people need more medicine. But it's all about how you dose it and how you time it and how much you take all at once. But if you need to reduce off time and increase on time, you could put the doses closer together. You could use continuous release or extended release formulations, which have been available for a long time. You could use other medications to reduce off time between doses. And then if you have too much dyskinesia, reduce levodopa taken all at once. Or you could add amantadine, which can reduce dyskinesias. Or you could consider stopping the monoamine oxidase B inhibitors or the catechol O-methyltransferase inhibitors, because those are making your overall dopamine levels higher, and then you're going to be more likely in the dyskinesia range. So over time, the evolution of Parkinson's is that your medicines will change. Usually they'll change. Maybe they should change. If not, you're sort of getting by. I want to talk one slide about surgical treatments, just so people are familiar. I'm not a neurosurgeon. I'm not recruiting people to do neurosurgery. Sometimes people who come to academic centers like KU, they're worried they're going to be like, oh, they're going to try to give me a DBS. We just like people to know what the options are. And that's because, as somebody who worked with a lot of people, many of my patients when I had clinic were not interested in DBS, and that was fine. We would try to use the medicines the best we can. But it would be unfair to say that if you ask people who have been in studies looking at quality of life for deep brain stimulation, not a week after they had brain surgery and they're still recuperating and that was miserable, but a year later, where they've had a chance to adapt and have their deep brain stimulator work and they're back to the swing of things and they're doing better. Quality of life scores are much higher when people have had deep brain stimulation. And that's because they're not dealing with this roller coaster all day long of, am I going to be on? Am I going to have dyskinesia? And then I'm moving too much. Especially if their doctors have not individualized their regimen to be so clean that it's going to cover you effectively. So this is why you will reduce the amount of levodopa you take because you're getting electrical stimulation. So you're not going to be in the dyskinesia range very often, if at all. We can almost always promise 25% less levodopa just by having a stimulator in. Some people have even been able to come off most or all of their levodopa, although that's not the rule of thumb. There are different targets. There are different companies. When I was trained, there was only Medtronic. Now we have Boston Scientific and Abbott, just in the last 8 years, have come out with these 3 different stimulators. So there's some competition. Good old capitalism, right? Can end up, improving the product. And now we're seeing people end up having high-tech adjustments of how to program their DBS. Instead of just using microelectrodes, they can even send the signals around or do some different strategies with this. So it's changed so much. Duodenal levodopa, people who don't want to have a brain surgery. If you have a PEG tube, like a feeding tube, but it pumps in throughout the waking day, a very even individualized dose of levodopa gel, then you can avoid a lot of these ups and downs. And so that's been an option for some people. It's been out for almost 9 years. And then there's also MRI-guided focused ultrasound therapy. So this is the idea, without actually cutting the brain, if your skull is shaped in a way that's amenable to have the MRI guidance, and then they're able to use sound waves to send strong beams and injure the area where a person has tremor in the thalamus, then they can reversibly cause damage and then make sure they're in the right place, and then turn it up and then cause irreversible damage, and the tremor circuit is cut. So then people's tremor goes away. So that's something, especially if people are not responding to the medicines or they have a refractory tremor, that might be an option for some people. I want to say a few things about some of the non-motor treatments. So we're going to bring up conditions again. These are not just symptoms, but they're also disorders that people have. So if people sit up or stand up quickly and then their blood pressure drops and people are lightheaded or almost passing out, fluid status is really important. Compression stockings are hard to get on and off, but abdominal binders often compress the vena cava and promote better blood flow back to the heart. And these can work if you're only dropping maybe 10 or 15 points. If your blood pressure, we have some people who are dropping 20, 30, 50 points, you're probably going to need medicines. I don't love to prescribe these medicines because it's just more pills, but if you do not get that under better control, it will see you in the hospital. People are going to be falling, they're going to be hitting their head. That's going to be a setback cognitively. This is often the beginning of people not functioning well. And so droxidopa is a medication that's FDA approved for neurogenic orthostatic hypotension. Midodrine has also been around a long time. They almost took it off the market, but it's still available. Fludrocortisone. To a lesser extent, some of these other acetylcholine and norepinephrine medicines can be used if nothing else works. But it just underlines how important it is to try to get that under control. Dopamine agonists sometimes have to be decreased and stopped because they feed into this dropping of blood pressure. There are a lot of folks, even after the age of 70, which I don't consider that old. I mean, in my mind, as a movement disorder specialist, 85 is probably old. But if you tell any of the people who are over 85 that I said that, I might deny it. But if you're 70 and you can't tolerate a dopamine agonist, you might have to come off of that and just use levodopa, because that's going to feed into more injury and even passing out. Abnormal sweating. There can be extra cooling vests or hydration, sometimes extra carbidopa because levodopa itself can cause sweating. There may be other medications that may be causing the problem. Sometimes people are on pain medicines or other antidepressants or things, other hormonal treatments that are causing them to have imbalances and more likely to sweat. So it's not something that's just annoying. It can be very disabling for people. Decreased bladder control. The problem is a lot of these medicines block acetylcholine in your nerve endings in the bladder, but they also, some of them get into the brain. And so oxybutynin is the one that everybody likes to cover because it's super cheap, but this can make people more cognitively impaired. If people would switch to even another generic acetylcholine anticholinergic that doesn't penetrate the brain, people would do better. And so I think, there are some of these other ones that I've mentioned here that are covered by insurance. Some of them do require like a prior authorization. But if somebody's having short-term memory loss, word-finding difficulty, it could be your bladder pill. I've seen people 50 years old affected by this. Oh, thank you so much for bringing this up. As soon as mom switched that bladder pill, within 3 days, she was like so much more coherent. Like you literally feel like a hero. but it's that meaningful. It's that noticeable for people. But we have, some of our neurologists are prescribing these, not even just like primary care, because they're like, well, it's going to be helpful. We know these pills work. They've been around a long time. They get in the brain, they make it worse. All of our dementia and Alzheimer's disease people stop this stuff immediately when people come in with memory loss. Other older tricyclic medicines can also be used for bladder, but they're also anticholinergic, so that people can be groggy or have worsening balance with those. Botulinum toxins, even neurostimulators exist for bladder control. As far as other autonomic issues, erectile dysfunction, I mentioned some things here. There's still a lot of room for study, and having better treatments also for women sexual dysfunction as well. There's still a lot of opportunities for growth there. Drooling. Glycopyrrolate is a pill, but it's anticholinergic, so it's systemic. It would be better if people would get atropine eye drops, like for glaucoma, and put one of them under the tongue. Even one drop is really strong. If you put like 2 or 3, you're like, it's the Mojave Desert in your mouth. But just sometimes they need to be done several times a day. But that can reduce drooling quite a bit, and it doesn't have a lot of systemic effects like glycopyrrolate. Even black tea has tannins in it, which make the saliva thicker, and you're less likely to drool. And then there's also a type of botulinum toxin called myoblock that they found was disproportionately more likely than Botox to cause dry mouth. So they said, let's use it for drooling, and it was just right. Constipation is a huge issue. There are docusate stool softeners, herbal laxatives people take, like psyllium or senna. Bisacodyl, it can be tablets or suppositories. Polyethylene glycol, it gets used a lot, Miralax. But there are other treatments too, like lubiprostone or linaclotide, that GI doctors are more familiar with, that can help reduce some of the burden without causing a lot of side effects. Seborrhea, so skin changes of the face and hair and scalp. People will start having kind of like dandruff or other peeling of the skin. Selenium sulfide, other like pyrithione zinc, which is essentially like Head and Shoulders anti-dandruff. Coal tar shampoo, ketoconazole is an antifungal. Steroids even, topically. Sodium sulfacetamide. So, selenium sulfide is Selsun Blue. So these are things that are often available over the counter, but you can escalate to prescription treatments as necessary. Sleep disorders. Melatonin gets used a lot. It's actually helpful for a lot of people who act out dreams. Some people don't respond to it. Tricyclic medications can help with sleep, although they can have some cognitive side effects. And same with gabapentin. But Ambien or Zolpidem is one to try to avoid. People who have Parkinson's are much more likely to act out dreams on these treatments. And then there's also suvorexant or Belsomna. That's sometimes used by sleep neurologists or other sleep specialists. It can rarely worsen or act out dreams. Fatigue, some of it is like efficient activity planning throughout the day. Exercise, people say, I would feel tired. You actually will have more energy once you exercise on a regular basis. So if you have not started to exercise by now, this is something that it's an investment, but overall you will have more energy during your week because your body will be functioning better biochemically. Don't do it for your heart disease or your stroke risk reduction. People are not doing it for those reasons, right? So do it because you just literally want to feel better. You may feel terrible when you're exercising because all the adrenaline makes all your movements worse. But after those 20, 25 minutes, the adrenaline is burned off. People are functioning better. The rest of your day and night and your sleep quality goes better. Sensory symptoms, dopamine agonists, like things like wearing off, analgesic pain relief, muscle relaxants. You have to be careful as all these medicines start to interact. Cognitive changes, the only medicine that's FDA approved for Parkinson's disease dementia is rivastigmine, which is available in capsules or a transdermal patch. And it's very interesting, once the patch came out and some of my patients wanted to do that because they had nausea and they didn't want to take pills, immediately so many people started walking better. Like the number of falls. And then finally, 5 or 6 years later, they did a big study in Lancet, and they were like, yeah, when people use the rivastigmine patch, they're falling less. It's incredible. So memantine is FDA approved for Alzheimer's disease. It is not routinely used in Parkinson's disease, but there are some people who have had benefits. If you have a lot of hallucinations, it may not be a good option, but for some people who just need some extra boost with cognition, it might be worth a trial. Not FDA approved. Depression, many types of treatments. Some people even will, if the medications will not work, they will have electroconvulsive therapy. Fearfulness, anxiety, panic attacks. You can tell because people who have never had these problems their whole life, now they're 55, 60, 65 years old, and they're starting to have these problems. And it's like, okay, they've been an adult their whole life. It's not poor coping. It's literally the changes in the brain from the disease. It's neurological. But the medications that you would have never taken your whole life can help. Have a discussion about it. Have a trial. Say, you know what, I don't know if I like the idea of pills. I don't like the idea of pills. I wouldn't want to take those pills either. But if you're not functioning well, try it. Say, we're going to work with my provider. We're going to try it for 1 month. And we're going to see how I do. And get some feedback. Are you feeling better? Are you functioning better? It's not, the stigma of mental health needs to go away. This is literally biochemistry in your brain. People with epilepsy have these problems. People with multiple sclerosis have these problems. People with Parkinson's have these problems. If I give you medicines to increase dopamine, because that's good for your Parkinson's, like levodopa, that's good neurology. But if I give you a dopamine blocker to help you with psychosis, like quetiapine or Seroquel, that's good psychiatry. We're literally working with the same receptors. So this idea of mental health is like existing in a vacuum, or you're just like not, you need to toughen it up. This isn't like that. These people are tough, but the changes in the brain would make anybody act like this. Pimavanserin is FDA approved for psychosis. Has anybody heard of this? A few. So this has been around for quite a few years now. It's probably 6, 7 years. And so if people are having delusions or hallucinations, there are treatments for this. Some people, for example, are more likely to have a delusion. I really feel like the neighbor is, trying to monitor us and report us to the FBI, or I'm thinking that my spouse is having an affair. These are real things that happen to Parkinson's disease, and many times even movement disorder specialists are not asking about these things because, like, how do you ask about that? Somebody literally thought their wife was having an affair or their husband was having an affair, and some of them were having an affair. But ultimately, it's like, how do you know? People would just think like that's not a neurological issue or something I would talk to my movement disorder specialist about. These are often underrepresented, but there are treatments for these things. And then avoiding medicines that block dopamine, especially Haldol, Reglan, and Compazine. I could talk for an hour about everything on this slide. I'm not even going to talk about it. I'm just going to put it up here. This slide, I just updated recently, even since our Blue Springs talk on March 9th. These are, if I showed you a list of every type of treatment for Parkinson's disease that they're working on, I would have to have probably 5 of these slides. These are just the ones that are the most likely. They've already jumped through enough hoops where they have a reasonably good shot of getting approved. So if nothing, if you wanted to take a picture or if you wanted to write some of these names down, you could follow along on the internet and be like, what happened to that? What's going on? I'm actually, I'll share with Michelle and Luann, I'm actually going to give a talk in Warrensburg, Missouri on May 8th, where I'm just talking for an hour about potential upcoming treatments. And I'm going to talk about a lot of this stuff. So if you guys would like for me to come back and go over some of the same stuff with you, you don't have to wait 2 years for me to come back. I'm happy to come back to Lawrence. I actually live in Lenexa. It's super easy for me. Michelle has to come all the way from the Northland. So, these give me a lot of hope, because when you see that 2/3 of the medicines that have been approved for Parkinson's have just been in the last 21 years since I graduated medical school, many or all of these or most of these may end up being approved in the next 3 to 5 years. So these are potentially new options to help people. And they work on different things. Some of them are for motor things. Some of them are for cognition. Some of them actually, the ones near the bottom, are actually looking at disease modifying and maybe slow the progression. And so I want to finish with some common misconceptions. These are misconceptions that doctors make, not patients. Use the lowest dose of medication is best, and then they'll use 10 100 milligrams of carbidopa levodopa. When you have less carbidopa, you have more side effects. Use the 25 100. If you need to use, instead of 25-250, take 25-100 pills and take 2.5 of them. You'll get 250 milligrams of levodopa, but the carbidopa will reduce side effects. Taking levodopa with food is important to reduce nausea. Yes, pharmacists will say this, and they're absolutely right. But if you take it with food that has protein, 30% less gets absorbed. So when we're talking about a roller coaster ride of already unpredictable levels, trying to take your levodopa at least 20 minutes before food with protein is going to go better for your absorption. Or otherwise, you have to end up waiting 90 minutes afterward. It's not symmetric. You can take it with some food. Take it with some plain crackers. Take it with something that doesn't have a lot of protein. I like the cheese and peanut butter crackers, but those have protein in them. So, you can take those a different time. Dosing the medicine 3 times a day. This happens all the time when people go to the hospital. 9, 3, and 9. Waking day. If you only are having symptoms during the day, only about 15% of people with Parkinson's need 24-hour levodopa because they'll wear off in the middle of the night and they can't wake up and can't get back to sleep. It would be better if you wake up at 8 a.m. to take the medicines like 8, 1 o'clock, 6 o'clock, and then have them be on board during the daytime, and then you have less dopamine at night when you're trying to sleep and have all these vivid dreams and nightmares. You do not have tremors, so you do not have Parkinson's disease. 20 to 25% of people don't. My favorite, you did not improve with 100 milligrams, 1 tablet 3 times a day, so therefore you do not have Parkinson's disease. The first week I was a fellow in Houston, I learned that if you have not tried 7.5 to 10 tablets of levodopa in 1 day, we don't know whether you're a responder. There are some people who just need more. 1 tablet 3 times a day is to make sure you're not having side effects. And people stay on this for years, and then they're wearing off and like they're only covered for probably 30% of their day. It's literally a tragedy. The other thing, I'll have a 5A and 5B. I had a patient 10 years ago who had seen 3 neurologists, and the neurologists were waiting to give her levodopa because there was some idea back 30, 40 years ago that we shouldn't, if we start giving people levodopa, they're going to have dyskinesias. It's the brain changes that are causing the dyskinesias. You can wait as long as you want to start levodopa. If you wait 9 years, this lady could barely walk. She was dragging in her leg. I literally wanted to make a citizen's arrest. But there was but they would save this. And so if you wait 9 years and start levodopa, within 3 months, you're going to be having dyskinesias. If you would have been covered with levodopa for the last 6 years, I'm not saying you have to start with meds right away, mobility would have been better. Some people can actually still work if they're more mobile. Then, over time, as your brain changes, you may start to have dyskinesias 3, 4, 5 years after that. So it's not the medicine, it's the more that the brain has changed and is more sensitive to the medicine. It's not the levodopa has caused this problem. This is an old one. Patients should never take more than 800 milligrams per day. This was before the internet. I had to find old books because I had a doctor tell my patient, what is this guy doing? He's giving you like 1,500 milligrams of levodopa. 2,000 milligrams of levodopa have been some of my patients because they wear off like an hour and a half after they take the pill. You have to individualize the dose. In the 1980s, long before the internet, there was apparently some concern briefly by the FDA that most people don't need more than 800 milligrams. That's not true. Movement disorder specialists easily will use, like I said, 7.5 to 10, 750 to 1,000 milligrams just to figure out whether you're responding to levodopa. And then other medications should be used for as long as possible. So definitely not something that, that theory has changed. We even give people in the first year or two of Parkinson's disease levodopa if it's going to help them, their quality of life and mobility, because we're not afraid of dyskinesias. We will individualize your dose so that you minimize that. These are my colleagues. All 4 of them have clinic. I do not. But I have to share one piece of bad news. If anybody's tried or is not in the system to get an appointment, as of even 2 weeks ago, 3 weeks ago, the wait times are June 2025. It's 15 months now to get in with a movement disorder specialist. So vote early and often. I will add some good news. My medical student is now a fully trained neurologist, and he's finishing his movement disorder fellowship. I trained him at KU. Dr. Andrew Creed, he's going to be joining us in July. He's going to get a lot of the pediatric movement disorder specialists because Dr. Kaufman at Children's Mercy left and went to the Mayo Clinic. And he deserves it. He's brilliant. But that's a loss. And so a lot of those patients who are transitioning are probably going to get in with Dr. Creed. So he's not going to be booked out 15 months, but it's not going to be long before he's also going to be booked out because Dr. Lee joined us about 1.5 years ago, and she's booked out 15 months. It's just the supply and demand. So thank you very much for all the attention. I appreciate you coming. This is me with some of the founders of movement disorders. So to my left, on the right side of the screen, is Dr. Joe Jankovic, who I mentioned. He was my mentor at Baylor College of Medicine. I still have nothing but gratitude and respect for what he's been able to do. He has published more than 1,200 papers on movement disorders. Like, I'm not kidding. At one point, he was publishing about 50 a year. If I sent him an abstract, he would send me corrections within 12 minutes. And I know that because I can see the track changes on the Microsoft Word. Like, he's just, like, it's incredible. And he's in his late 70s and doing this. His mentor on the very left is Dr. Stanley Fawn, who I think finally retired. He's in his 80s now. And then Dr. Mark Hallett, who is 6'5", is seated at the table. And so he trained Dr. Richard Dubinsky on the very left, back in the old days at NIH. But he's now also retired. So this photo was taken 12 years ago. But thank you very much for having me. Maybe in some of the time we have left, I know it was sort of longer than a usual support group session, but for those of you who still have energy and enthusiasm and want to have some questions and answers, I would be happy to answer some of them. We could do it publicly, or if you want to save it for a little bit, we'll talk to you privately afterward. But yes.
Is massage effective for reducing pain from tension from Parkinson's?
Yes, but no insurance companies will cover massage. So the question is massage effective for pain relief? Many people say that it is. In fact, one of the doctors I know, who I won't mention, he himself goes and gets a massage every week because he has a lot of tone problems. And so it makes a big difference for people who do it, but it can be very pricey. I want to mention, since I really didn't talk a lot about therapy in my talk, therapy early on is often very helpful. Sometimes doctors are waiting until they're 3 or 4 years into the course of their Parkinson's disease to offer occupational therapy, speech therapy, physical therapy. It can be very meaningful, and they'll even talk to you about things that you didn't realize were related to Parkinson's. And they can even just assess you once. It doesn't have to be that you go every week for 3 sessions for 4 weeks. Just go once or twice, get some of the knowledge, implement it into your life, and they can also do a lot of stretching and other strategies to try to take some of the pressure off some of the aching muscles. Great question. Yes, sir.
Can you speak on the alpha solution, probably mispronouncing, as far as is it identified as a causative agent? And also talk about the connection with the gut, and is it related to a prion-like situation?
High-level question. So the question is alpha-synuclein that builds up in brain cells, especially dopamine-producing brain cells. Is this the cause of Parkinson's, or what's the relationship with the GI tract and the gut and the chronic constipation? So there's no question that alpha-synuclein is a protein we all have, but it normally folds correctly. And it's nice and structured, and everything's behaving correctly. But then what can happen is alpha-synuclein that mutates can start to cut its own self. I almost think of it like as if you had 2 machetes and you start doing a dance. Like something's bad is gonna happen. So if it cuts itself, then the protein will misfold, and then it's more likely to build up abnormally. Many people historically have said, if we can stop alpha-synuclein from building up, that's going to arrest Parkinson's. And I've even said that in previous talks. But they developed some vaccines that were going to block alpha-synuclein, and those have not made it past like phase 2 trials. Because what ends up happening is, we've seen this a lot with Alzheimer's disease and amyloid. So when amyloid builds up in brain cells, does that cause Alzheimer's disease? Or is the Alzheimer's disease allowing amyloid to build up in the brain, and so it's like a bystander? And so that's been difficult to prove. One of the treatments that I mentioned here, which is UCB0599, is actually an oral inhibitor looking at blocking alpha-synuclein misfolding to try to answer this question. Because if they had something that was reliable that would work, that you could get into the system, then we'll have a better sense. But there are some people like Dr. Alberto Espe, who helped train Dr. Creed, who's coming to join us, when he was a resident at the University of Cincinnati, who was, he's been very outspoken about how are we interpreting these data points correctly? And is it the chicken or the egg? And I think he brings up some very good points. So when things don't work in research, instead of saying we need to do more of the same research, we need to also think about other angles of research. And I'm a proponent of that. I think that's why I like all these different treatments, is they're going to look at different components to see if people will do better. Now, to answer the part about the gut, the theory is that if abnormal prions, abnormally misfolding alpha-synuclein ends up going through the nose, then people lose their sense of smell 5 to 8 years before, and then it makes its way to the brainstem where people are acting out dreams, and then they start getting to the dopamine cells, and then you start to see the motor symptoms. And this has been the sort of progression that a lot of people have, but other people, it may enter through the GI tract. And so the enteric nervous system, they have found Lewy bodies, which is essentially alpha-synuclein clumping in the nerves of the intestines. And so, the gut-brain connection is very alive and kicking. 80% of serotonin in the body is in the GI tract. So when you think about these neurotransmitters, this is why Zofran with nausea, it's like works on serotonin, 5-HT3, by blocking that, and then people's nausea is better. And then, so prions are abnormal proteins that cause disease. So if you thought it was bad enough to have a bacteria, which is actually a living organism, infect you and cause a disease, and then virus is not even alive, it's just RNA or DNA that gets into your system and then you make a bunch of copies. This is literally the lowest thing ever. It's like a protein that causes disease. It's not even alive, but it comes into your body and starts. So if you think about mad cow disease, that was a prion disease. And so Stan Prusiner, who won the Nobel Prize, I believe in 1997, looked at alpha-synuclein and said, I think this is the first prion we've found in 50 years. So, he knows a little bit more about prions than me. So I take his word for it. But great high-level question.
It's not high-level question, but under causes, you had wood burning stove.
Yeah, so causes exclamation point. So it's been theorized that exposure to toxins, free radicals, when a person burns, has a wood-burning stove, some people grew up in that environment. The problem is that there are many people who grew up around a wood-burning stove for many years of their life who never develop Parkinson's disease. So it's the exposure plus the series of events, head trauma, viruses, genetics. They estimate that by the time really the layers of genetics are understood, that up to 35 or 40% of Parkinson's probably has genetic components. But what if you inherited 12 of the 18 genes? Like when I was a fellow, there were only 8 genes that they thought caused Parkinson's. Now the list of suspects is up to about 40. But if that was really identified and it was well understood, people could lose the genetic lottery and have lots of different mutations, and each one raises your risk by 12%. And by the time you have all of these, then you could be like 600% more likely to have Parkinson's. And so that's why that's like, it doesn't run in my family. Well, because there's spontaneous mutations and exposures and all these things. So it's a very complex picture. One of the values of like the PD gene study that the Parkinson's Foundation is doing, to go back to this one, if you look at the BIA 28 in the kind of 2/3 of the way down, 6156, this is actually a treatment that will replace the enzyme if you have a GBA1 mutation. So if we identify what mutations people have and then come up with individualized treatments, they might not work for most people with Parkinson's, but they might work for you. And this is where, and then LRRK2, like the BIIB 122, that's working on LRRK2. LRRK2 tends to be increased in Parkinson's disease. So if you inhibit that, that might actually slow the progression. So there are all these angles. These are just the ones that are probably going to have a decent shot. Like they might, if they just do 6 more months or 1 more year of research, they might have something meaningful that they could bring to the FDA and say, we want this to be approved. You look at it and tell us what you think. And then sometimes, like for example, that medicine that's going to potentially be looked at tomorrow, they brought that to the FDA back in 2020. But they were like, you don't have enough evidence here. They had to hit back to the lab and start not from scratch, but they had to work through all the organized things that the FDA gave them. And then now they're trying again. And they may be very successful tomorrow.